In our last lecture, we began our discussion of the counselor as a person and as a professional. Today, we're going to continue that discussion by talking about transference and countertransference. The concepts of transference and countertransference were first introduced by Sigmund Freud as part of his psychoanalytic theory, but these terms have now been adopted by many other theoretical orientations. Now, in general, transference refers to the client's reaction to the therapist, and countertransference refers to the therapist's reaction to the client. We're going to begin by talking about transference. So, with transference, clients project onto the therapist past feelings or attitudes they had toward significant people in their lives. So they're reacting to the therapist as they have reacted to other important people in their lives in the past. Typically, it's reacting to the therapist as if they were a caregiver from childhood. So often, clients react to their therapist as they did to their mothers or fathers in the past. But it's not limited only to your caregivers, it can be other significant people in the client's lives. So this reaction causes a distortion in the way the client perceives and reacts to the therapist. So the client is not reacting to how the therapist is presenting in the here and now. They're not reacting to how the therapist is really behaving. They're reacting to the therapist as they've reacted to other important people in their past because they have a distorted view of the relationship with the therapist. Now, if these transference reactions are attended to and worked through, it can help the client gain valuable insight into how their past relationships and unresolved conflicts from the past are influencing their present relationships. So, for example, let's say the therapist gives the client some feedback about something they've done, and the client immediately gets very defensive and feels attacked. And in past sessions, the client has said that their father was overly critical and often very judgmental, and they often felt attacked by their client, by their father as a child. So the client is telling the therapist that they often felt attacked by their father in their childhood. When the client receives some feedback from the therapist, they react as if they're being attacked and become very defensive. So a therapist who's able to recognize this and help the client work through it might share with the client that, you've mentioned in the past that you often felt attacked by your father. I just gave you some feedback and you seem to really have a strong reaction to that feedback. So I'm wondering if you're having some of the same feelings toward me that you had toward your father in the past. And if the client, receives that and agrees with that, then the therapist can help the client work through, does this come into play in your other relationships? Are there other times when maybe bosses or partners or somebody has given you some feedback and you felt very attacked and have behaved very defensively? That can help the client understand how these unresolved conflicts may be influencing their other relationships. Now, just because transference can occur doesn't mean that the therapist should ignore the client's here and now reactions to them. If your client perceives you as overly critical and as if you're attacking them, you can't automatically dismiss that as transference or assume that's transference. Maybe the client is reacting to how you actually are as a therapist. So you don't want to just assume something is transference. You want to be able to do that reflection on yourself and how you're presenting to the client and see if the client is actually reacting to you or if this is some manifestation of transference. So again, transference is when the client projects something onto the therapist and they see in their therapist or they react to their therapist as if they are a significant person from their past, and they react to the therapist in a way that they've acted to these people in their past, and that represents a distortion of the relationship with the therapist. Now, countertransference refers to the therapist's reaction to the client. So in the past, this is referred to any projections by the therapist that distort how they perceive and react to the client. So very similar to transference in the past, countertransference very specifically referred to any projections that the counselor is making onto the client. So any of the counselor's past unresolved issues, unresolved relationships, and them reacting to the client in a distorted way that is a representation of those old relationships. So that's how the term countertransference was used in the past. But currently, it's used in a more broad, more general sense, just to refer to the therapist's total emotional response to the client. So any emotional response the therapist has to the client can now be considered countertransference. That can include things like being overprotective of the client, not challenging the client or not pushing the client because you want to protect them. You want to, of course, you always want to prevent doing any harm to client, but there are times when clients may have to be confronted with some things that make them feel uncomfortable or asked to do some things that challenge them. And a manifestation of countertransference could be that you're overprotective of the client and you keep them from those experiences. Other times that can represent countertransference would be needing constant reinforcement and approval from your client, rejecting your client, seeing yourself in your client. So we want to identify with the clients, but we also want to make sure that we're seeing the clients as separate people. And just because they may have similarities with you, you don't want to be so blinded by seeing yourself in the client that you lose your objectivity and you are telling the client what you yourself may have wanted to hear and don't recognize that they are different, separate people. An example of countertransference could be developing sexual or romantic feelings towards your client. It can also include desiring a social relationship with the client. So maybe it's not romantic or sexual, but you find yourself thinking, okay, this client is really cool. I can see myself hanging out with them, and you desire, or you might even seek out a personal relationship with them. So that would be an example of countertransference. Another example would be giving your client advice. So in this field, we leave the client to discover their own solutions. We don't engage in advice giving. So if you find yourself telling your client what they need to do, that can be, a result of being overprotective. You don't want them to struggle with the decisions. You don't want them to possibly make the wrong decisions. So you give them advice. You tell them what to do. So these are all things that should sort of raise a red flag for you and say, hey, am I experiencing some countertransference here? So what are the clinical implications of countertransference? Countertransference can either be constructive or destructive in the therapeutic relationship. When countertransference becomes problematic is when it's not recognized, monitored, and managed. It becomes destructive when the therapist's own needs or unresolved personal conflicts become so entangled in the therapeutic relationship that it obstructs their objectivity. So just like with transference, countertransference can reveal some important things about you as a therapist, how you react to people, and it can also reveal information about the client. If you're reacting to the client in a particular way, maybe other people in their lives react to them in the same way. So countertransference can reveal some important information, but you have to recognize it, monitor it, and manage it. It becomes really problematic and destructive when it gets so entangled in the relationship that you can't tell what's real, what's really a factor or a function of the relationship between you and the client in the here and now, and when your own personal needs and personal issues are overriding the reality of the client-therapist relationship. Another personal factor that can affect your work with clients is client dependence. So many clients experience a period of dependence, especially early in the counseling relationship. And that's not necessarily bad. That's to be understood. The clients come to you in distress. They perceive you as an expert. So of course, they're going to be somewhat dependent on you, especially in the early stages. So that's not a bad thing. When client dependence becomes problematic is when the therapist encourages that dependence. Now, that can be done for a number of reasons. It can be done for financial reasons, which we'll talk more about in a little bit. So maybe the therapist needs that client. Maybe they are hanging on to that client for financial reasons, so they encourage client's dependence. They continue to make decisions for the client and give advice to the client rather than allowing the client to develop that sense of independence and do those things on their own because they need the client to keep returning to therapy. Therapists can also encourage client dependence for their own psychological reasons. So we talked about that need for approval, need for admiration. Maybe they want to be the one to supply answers for the client. So the client is impressed with them and the client admires them. Maybe they like to be needed, so they encourage that client dependence. So again, client dependence can be encouraged by the therapist for financial or psychological reasons. Now, to encourage that dependence, therapists can offer quick solutions to the client. So rather than allowing the client to struggle and come to their own solution, the therapist may jump in and supply solutions for the client because of their own need for client dependence. And this really impedes the client's empowerment. It keeps the client from becoming independent and feeling as though they are able to be successfully responsible for their own lives. Now, we just talked about encouraging client dependence for financial reasons, and this would be delaying termination. So delaying termination or delaying the end of the relationship with the client can be a form of encouraging client dependence. And let me point out that delaying termination can be done on the part of the therapist or the client. So the client may want to remain dependent on the therapist, and the client may try to delay termination, or the therapist can try to delay termination of the relationship with the client as a way of encouraging dependence. So professional ethics codes have guidelines that call for termination when further therapy will not bring significant gains. So when you believe or you have evidence to support the idea that continuing therapy with this client will not render significant gains, it is your ethical obligation to terminate that relationship. So it is unethical for the counselor to delay termination for financial or their own emotional reasons. So you must learn to determine, number one, when termination is necessary, and two, how it can be done successfully in an ethical manner. There's no particular guideline for how to terminate with client. There's no hard and fast rule that, hey, termination has to be done at this time or termination has to be done at this way. It's up to you to determine when continuing therapy is not likely to cause a client to improve significantly. And then you also must determine what is the most ethical way to carry out termination or to bring about the end of this relationship. Open-ended treatments without clear goals are especially difficult to end because the client may experience termination as a personal rejection by the therapist. So that is one of the reasons why it's very important to have clear, measurable goals in therapy. Because clearly, when you have accomplished your goals, that will be a time to touch bases with the client and say, you came here wanting to accomplish these things. We've accomplished these things. Now would be a good time for us to end our current relationship. If you have any future difficulties, of course, you're always welcome to return, but this might be a time to stop seeing each other for now. So there, when you have clear-cut goals, termination is a lot easier, as opposed to when you have open-ended treatments with no clear goals. How do you then go to your client and say, okay, it's time for us to stop meeting weekly or to meet more infrequently or to totally end the therapeutic relationship at this point? Because you have no data about which to say, hey, it's time to end, the client may then perceive that as a rejection, making termination more difficult.